Good afternoon and welcome to the Thursday, November 5th, new report on COVID-19 and schools media briefing. Today we welcome Dr. Daniel Klein, Senior Research Manager for the Institute for Disease Modeling, Lacy Fehrenbach, Deputy Secretary for the Department of Health, and Dr. Kathy Lofi, State Health Officer, Department of Health. To begin, we'll open with a presentation from Dr. Klein and then move to Q&A from reporters who have entered the queue. With that, I'd just like to remind our media attendees that today's briefing is limited to inquiries regarding schools and COVID-19. We'll have other opportunities in the following days to answer questions about general COVID response questions or other policy decisions around the response. So with that, Dan, I'm going to make you presenter and we'll open.
Good morning, everybody. Thanks for the opportunity to present our new school modeling work. In just a minute, I'll share with you some slides that capture the highlights that are found in the report that we've made public today. The report is called Testing the Waters, Is It Time to Go Back to School? This is work that I've done with collaborators at the Institute for Disease Modeling, which is part of the Bill and Melinda Gates Foundation. So I'm excited to share with you these new results. The focus of this work is on the potential benefit of diagnostic screening for school populations, weekly or fortnightly testing of all students, teachers, and staff, and the potential that might have for reducing risks of in-person learning. So this work, as in our previous two reports on this subject, are based on a model that we developed purpose-built for this type of work called COVASIM. This is an agent-based model, which means that we're representing individual people within the model. You could think of it as a serious computer game. We track infections, as you see in the picture in the top right, as well as the person-to-person contacts on which those infections are acquired and transmitted, including household, contacts, workplace, community, and of course, schools. A couple key definitions for today. We'll be talking about diagnostics, focusing on PCR tests as well as antigen tests. Screening, and please take note, two types of screening will be discussed today. The first is symptom screening. So this is like fever, or chills, difficulty breathing, that sort of thing, symptoms. And diagnostic screening, where we're using one of the above diagnostics. And finally, countermeasures. These countermeasures are things like NPI, that stands for non-pharmaceutical interventions. These are things like physical distancing, hygiene, masks, ventilation, that sort of thing, in addition to symptom screening as well as contact tracing. So I mentioned this is now our third report in this series. I wanted to briefly cover the main findings from the first two reports. The first report on the left, titled Schools Are Not Islands, and there what we found is that the risk of in-person learning is not zero. It depends primarily on two things. The first is the countermeasures that are implemented in and around schools. And the second is what's happening out in the broader community outside of the schools themselves. The follow-up report, we were better able to model sort of day-of-week factors and therefore look at hybrid scheduling and the K-5 phase-in. And we again found that worst case outcomes are possible, but those risks could be considerably reduced through the phase-in approach, hybrid scheduling combined with countermeasures. We did note in that work that with more scheduled remote days, you have fewer opportunities for in-person learning. So that brings us to the new report, Testing the Waters, Is It Time to Go Back to School? Again, the focus is on now diagnostic screening, which is not something we had considered in our first two reports. The setting of this work is King County, Washington, as of mid-October, and we note that there have been increases in transmission since we developed this work. So the situation here is about 75 cases per 100,000 over 14 days. A 2.5% positivity, a prevalence of 0.2%, and we're modeling a relatively constant situation. So the reproduction number in these computer simulations is 1.0, and that signifies that each infectious individual will pass the infection on to about one other person on average. We'll be looking at K-12 schools over a 3-month period. Nominally, it's November 2nd through January 31st, but we're not simulating holidays, so really this could be any 3-month block of time. So we're considering a number of school reopening scenarios as well as diagnostic screening scenarios. These school reopening scenarios are first a full schedule without countermeasures. So you could think of it as like school in 2019 or 2018, 5 days per week without concerns for COVID. And we'll see you can get unchecked growth in that setting. Then 3 scenarios that add those countermeasures we discussed: a full schedule, hybrid schedule, and a phased-in approach. And finally, an all-remote scenario, very much like much of the state that is in today. On the right, you see the diagnostic screening scenarios we consider. In gray, as in our previous work, no diagnostic screening. Several scenarios in blue that are based on PCR diagnostics, either 1 week before the first day of in-person learning, or at different frequencies, fortnightly or weekly. And the red ones, similarly, are just using antigen-based tests. And note that there is one of those that does antigen testing in just teachers and staff, whereas the other ones are in students, teachers, and staff. Because antigen tests can have false positives, we do PCR follow-up. That's the F/U in that legend. So that brings me to the first set of results. Here you see a bar chart. The height of the bars in this chart represents the percentage of students, teachers, and staff that might acquire a COVID infection over the 3-month analysis window. That source of infection could be any source. The infections could be acquired at school, at home, or elsewhere. And across the bottom, you see the different scenarios that I mentioned. 4 key findings to call your attention to here. The first is that there are no zero-risk scenarios. You can see none of these bar heights are 0. So even in an all-remote scenario, there still is not a zero-risk scenario. People can acquire COVID at home or in the community or elsewhere. The second key finding I'd like to call your attention to is that the countermeasures are really quite effective. And to see that, look at the height of the bars in the leftmost group, the full schedule without countermeasures, compared to the full schedule with countermeasures, which is that next group of bars to the right. And notice the difference in the Y-scales. The left axis goes up to a full 35% could be acquiring a COVID infection over this period, whereas the right scenarios are on the blue axis, where the height is just 2% at maximum. So the difference that those countermeasures make is really quite striking. The third key finding is that the hybrid and K5 phase-in approach, those 2 groups there in the middle, are not significantly riskier than the all-remote approach. And finally, we note the benefit of diagnostic screening. That's the colors of those various bars. Diagnostic screening is really most helpful when there's lots of transmission happening. So all the way on the left, the full scenario without countermeasures, you can see almost a factor of 10 difference that weekly antigen screening adds on top of doing no screening whatsoever. But looking at the hybrid or K5 phasing, you can see that there's a much reduced difference in this percent acquiring COVID with the addition of routine diagnostic screening. The second set of results looks at what might happen in the entire community were we to reopen schools for in-person learning in different ways. And so here, the height of the bar represents the reproduction number. This is how many onward infections are caused by each infection on average over the 3-month period that we analyzed. 2 key findings here. The first is that in-person learning with countermeasures doesn't seem to dramatically increase the reproduction number. We're starting around 1, and you can see that as we go to hybrid, K5, and even a full schedule, the levels stay about 1. These little black bars are indicative of the fact that our model is simulating sort of noisy events, lots of coin flicks, and there's still some uncertainty in the modeling results. The one scenario that does creep above 1 is this full schedule with countermeasures, and you can see in this case, the second key finding, that diagnostic screening is able to bring that level back below 1, with either fortnightly bringing it about to 1, or weekly antigen screening it below 1. Of course, the full schedule without countermeasures does result, as we've shown in previous work, in increases in the population-wide reproduction number. The next set of results looks at the percent of schools that might have an infectious individual present on the first day. And this is after symptom screening, so filtering out people who are clearly showing symptoms. And the first key finding here is that the probability increases with the size of the school. So in the figure on the right, the x-axis is the size of the school, the number of students, and the y-axis is the percent of schools that might have an infectious individual present on the first day. That individual might never be detected, they might not be diagnosed, they might not pass the infection on to anybody. And this is just showing kind of a common sense result that if you've got a big school with lots of people, the probability of having one or more infectious individuals present is higher. And now we look at the benefit of adding diagnostic screening a certain number of days before that first in-person learning day. So in the light blue is if you do diagnostic screening, all students, teachers, and staff, a full week before the first in-person learning day, down to pink where you would do it theoretically on the first day of in-person learning. And what we see is that if you do diagnostic screening a full week in advance, the impact is marginal. That blue line isn't much below the black line. However, as the screening approaches the first day of in-person learning, you can see the benefit grows. And my last chart for you today is looking at the percent of school days that would be taken as remote. In this modeling, I mentioned we're looking at a 3-month period, not considering holidays, and the result is 65 possible in-person learning days. And the two key findings here are, first, the percent of days that would be taken as remote are dominated by scheduling. And the way to see this is across the 4 different school reopening scenarios in this chart for teachers and staff on the top and students on the bottom. You can look all the way to the right and you see the scenario in which we're modeling an all remote scenario. And there, of course, all of the days are taken as remote learning. As you move left to either the hybrid or K5, you see that those scenarios schedule in about 2/3 of the days for students to be remote, 2 out of every 5 days in hybrid, and just the middle and high school for the K5 in-person scenario. What was surprising here is that the contributions from diagnostic screening and symptom screening are relatively small. And you can see those in the full schedule with countermeasures. In that scenario, what we're doing is performing diagnostic screening, as you see according to the different colors, and symptom screening, and those tests can have false positives. The individuals could be screened positive and sent home for some period of time, and that does increase the number of days that would be needed to be away from school. The point is that those increases are relatively small compared to the scheduled remote learning days. So this is computer modeling. As in all modeling exercises, there are many assumptions that we've made in order to produce these results. I encourage you to look through the complete list of assumptions that can be found in the modeling report. So just briefly, we'll conclude with some key takeaways and discussion. What we find is that, again, in-person learning is not a zero-risk activity, but we see that symptom screening and other countermeasures can be effective in mitigating those risks. The impact of the diagnostic screening, really the focus of this work, is limited to some extent by the impact of countermeasures in this low prevalence setting. We also saw that a single PCR test a full week before the first day of in-person learning, a small number of tests where we could just test, say, 10% of the population, or infrequent testing, say once per month or every other month, might not have a long-lasting impact on reducing risk, but we would learn a considerable amount by doing so. In terms of remote learning days or lost in-person days, we see that scheduling dominates those losses, but symptom screening, due in part to low specificity diagnostics, does contribute as well. As part of this work, you'll find in the report that we've done quite a bit of sensitivity analysis to try to check which of their assumptions matter the most, where we might have been wrong. And there we find something that we've seen before, going back even to our Schools Are Not Islands report, that one of the key uncertainties of what happens in schools is community transmission and the level of transmission that's happening outside of schools. So that's it. Many uncertainties remain. This is computer modeling, but nonetheless, we hope that these results are helpful in some way. Thank you.
Thank you, Dr. Klein. With that, we'll move to the Q&A portion of today's briefing. And change roles. And open with Ariel Dreyer from Spokesman Review.
Thank you. I'm curious what lessons or takeaways from this report can be applied to other communities in Washington State, especially in places like Spokane County, where our incidence rate is almost triple King County's.
Yeah, that's a great question. You know, doing this type of modeling where it's more detailed, we've been careful to keep track of, you know, the percent of the population that's enrolled in school, adults as they're going to work, and those scenarios look a little bit different as we look around the state, as does the nature of COVID in those communities. So in particular, we're modeling the King County situation here, and that has to do with the level of transmission as well as the level of testing and so forth that's present in these communities. As we look around the state, you would expect to see differences, and even we do see differences even within a King County type population. So I think it does speak to the original findings that as the level of transmission out in the community varies, we so would expect the level of incidence and new infections appearing within schools to increase as well. My suspicion is that the increases wouldn't be more than a factor of 2 or so, but we haven't done that work yet, so please stay tuned and we'll continue to work diligently.
Do you have a follow-up, Eric?
Yes, if I was hoping that one of the Department of Health workers on the call could address whether or not case counts are rising in kids that are 10 to 19 years old. We're seeing a spike in those cases here in Spokane County, and they haven't even gone back to school. So I'm curious if that's happening statewide and sort of what the recommendation would be in getting those older age groups back to school.
This is Kathy. I can start, and you know, so last week, I believe, on our Wednesday call, I presented the number of cases by age groups. And, you know, we didn't see, you know, there seemed to be increases in all of the different age groups in Western Washington. They all seem to be increasing at about the same pace, if I remember correctly. And I believe, and I don't know, Dan, you may know as well, since your team helps with those. I don't know, like specifically if it's broken down if the less than 19 or less than 18 group is broken down further than that. But it didn't appear throughout the state that we were seeing sort of a disproportionate increase in young kids or in kids in general. And feel free to chime in if other people have more information.
And for the second portion of your question about getting older kids back in school, I think, you know, we are concerned about the rise in cases we're seeing generally across Washington State and in all age groups. And, you know, certainly, as Dan has pointed out, the risk of COVID being transmitted in the school environment increases as the activity level and disease burden of COVID increases in the surrounding community. So, you know, when we are in a status where we're seeing a rise in cases, that's, you know, not the ideal time to be expanding learning. the good news is that when we have looked across the countries, we have seen, looked across our country, we have seen many schools and districts with rates, higher than what we see here in Washington that have brought kids back in for in-person learning. And that seems to also support, what the modeling has shown, which is, the real importance of those health and safety measures if you do in-person learning. In terms of older students, this is challenging. We do think, and the science is continuing to support that the risk is lower for children who are younger, probably because they are possibly less susceptible and less likely to transmit COVID. We see, lower incidence at the younger age, and if you look at data nationally, there are fewer cases and less transmission among elementary school students, and fewer outbreaks. So, if to get older students back in, we're going to really have to come together as communities and as a state to drive down our rates. And that's going to mean making choices about what types of things we do. So we're going to have to limit some of our social interactions and really focus on safer, smaller gatherings if we want to get especially our older kids back in school, but any of our kids back in school.
I can just briefly add to that within the modeling work, we have assumed that children under 10 are particularly less susceptible to acquiring infections, but children 10 to 19 are as well less susceptible than adults. And one of the things that we studied in the analysis was, what if that doesn't end up being the case? That is in fact what the latest science says, but if that's not the case, then we show that in fact you do get more infections, particularly in the student populations, with some small spillover to teachers. So you can look to the report to see that quantification.
Next, we go to Sally Ho with the Associated Press.
Hi, thanks for taking the call. This is the modeling for what could be, but can the health department talk about what it is now and where things stand among schools that have any in-person learning? What do we know about the schools that have gone back in some form, and in terms of outbreaks or infection rates in those communities, as well as what sort of best practices on testing, distancing, masking that they're following? Can you guys give us some context on that, what the situation is?
Yes, so when we look at national data, there's not a uniform national standard for collecting and analyzing information about school outbreaks and infections, but there is a great dashboard that is sort of the best data we have right now, that is run by some researchers at Brown University, and it includes data on, I think now, nearly 5,000 schools, representing a pretty large number of children. And generally what we have seen is that the infection rates in the school, so among students and staff, kind of trend what is happening in the community as this modeling does. So as the community rates go up, the transmission in schools go up. The interesting thing is that the infection rate for children does so far trend to be less than what is happening in the surrounding community. However, for staff, it's pretty close to, and I think 1 week of data, it was a little higher than what was in the surrounding community. In terms of outbreaks, we fortunately are not seeing the large outbreaks that I think many of us feared might happen with return to school. On this dashboard, you can look by state or nationally, and outbreaks with 5 or more cases are a very, very low percent. 1 to 3% of schools are reporting outbreaks of 5 or more cases, depending on the week. For the, I think they now have 6-week reporting periods, maybe 8 weeks at this point. Within Washington State, we have had handful of outbreaks since the start of school, dating back to August. Almost all of these have been small, fewer than 5 cases. We have had 4 that have had 5 or more cases, and 3 of these were in high transmission areas, so places with more than 75 cases per 100,000 over a 2-week period, and only 1 was in a moderate transmission community.
Do you have a follow-up?
Yeah, so, we're talking about, 10, maybe a dozen or so cases, but out of how many, like what's the percentage compared to how many have actually gone back, since we know most kids are actually home? So does this 10 represent like 50% of all the schools that have gone back? Like, can you put that into context?
Yeah. So that's a great question, and it's actually really complicated to answer. As it turns out, some of these outbreaks are in schools that are primarily remote. So they have very few students, or maybe even no students, coming into the buildings, and the outbreak is actually, among staff, for example. So it is hard to figure out that denominator that you're asking. We are aware that at the start of the school year, it was about 95% of students were in primarily remote learning, whereas, the majority, whereas only a small percent are going into the building either on a part-time or full-time basis. So we are still trying to get better understanding of that. I think, though, something that I could share is that among the outbreaks we've seen since actually over the course of the whole pandemic, we've had 43 outbreaks, 10 of which were before the start of the school year, so 33 more recently. There are 110 linked cases that have been reported to the Department of Health, and that's a very small portion of the cases we've seen among children, and in that 110, about half are staff and half are students. And that's an estimation based on the reported age of the person.
Yeah, and this is Kathy. I think I'll just sort of to sum up, for our experience here in Washington, we have seen COVID-19 be introduced into the schools, but I think one thing that's reassuring in our data is that we're not seeing large explosive outbreaks when COVID-19 is introduced into the school. And we think this is because of all of the safety measures that are in place. And that's consistent with the modeling report that Dan, just showed you, that these safety measures that we have outlined for all schools to follow in Washington appear to be very effective, and I think that that's really, a promising data.
Yes, absolutely. Thank you for adding that. And one quick correction: it's 42 outbreaks, and 32 of them have been since the start of the school year. I apologize.
Next, we'll go to Suzanne Phan with Como.
Hello there. I am curious to know about rapid testing, when and if it'll be available for our schools. We know that it's available in some states already, like California.
So we are looking at options for how testing could possibly help us get children back into the buildings for in-person learning, and add an extra level of protection beyond the health and safety measures we already have in place for those who do in-person learning. And there are multiple approaches that states are taking. So we are looking at the variety of them, including the use of rapid testing, We certainly have, the pathway of making sure people who have symptoms, students and staff, get a quick diagnostic test to either be able to return to school more quickly, and certainly if they have COVID, to learn that and stop the chains of transmission. There's some states that are using testing as an approach to respond to outbreaks in the school and curtail those. And then, you've seen some examples in a few states and in the modeling about using testing as a screening tool or a surveillance tool where you're doing either repeat testing of staff and or students over certain intervals of time. We are in the process of writing some guidance for districts that actually walk through all three of these testing methodologies so that if they want to run ahead and do some of these things, they can. And just to be transparent, there are districts and counties in Washington state that already are using testing for school populations, and simultaneously exploring some pilots among schools that are open in these three areas so that we have strategy that we could use in the next quarter, which, thinking January timeframe going forward. And that does include the use of these rapid antigen tests that many states are using.
I do have.
Do you have a follow-up?
Yes, I do. Thank you. If the science says it's safe for teachers and students to return to the classroom, what type of support will there be for educators to make sure that they feel comfortable going back to the classroom? Mental health support or just support in general for educators?
So we are, I think, having several discussions with stakeholder groups, including educators and school staff. I think for that question, I would encourage you to talk to school directors and the Office of the Superintendent of Public Instruction. We have been focused on helping the teachers and staff and school administrators understand the risks and how to mitigate the risks and feel comfortable with the balance of risks that we're taking for benefit of in-person learning and what the science is showing us, and really helping people, including families as well, to understand the science, and that it does appear that we can get children back into buildings without increasing the risk that the staff or students get COVID if we have those strong health and safety measures, and without increasing the surrounding level of COVID. And that goes back to Dan's great slide that shows the reproductive number of the virus. So, I think our focus in the COVID response has really been around mitigating the disease risk. Your point about mental health is certainly a really great one. It's just not exactly my area of expertise.
Next, we'll go to Natalie Swaby with Key 5.
Hi, good afternoon. Wanted to follow up. Lacy, you'd mentioned that a few counties are already using testing. Can you say which counties those are? And then wanted to make sure with this rapid test, results can come back in 15 minutes. Is that right?
Yes. So there are antigen tests out there that return results in 15 minutes. It's a card and a kind of a point of care test. It does still involve a swab. So that's your second question. And then we are aware and working with Okanagan County on some testing. And then there are a few others that are getting ready to go. And there may be more, but we are aware of those.
Yeah, one additional challenge that I'll add is that we don't have school nurses or health people in many of our schools to actually do the testing. The initial batch of the Binax Now antigen tests that we received were all sent out to the community health centers around the state because we wanted, teachers and students who were sick to be able to easily go to their community health center and get that test in 15 minutes. So that was sort of our primary, that was our first step in the distribution of Binax Now testing and the Binax Now test that we received. And now, we are working with schools to figure out the best way to use them. But one of the challenges we have is that, most of our schools don't have a full-time school nurse.
This is the other thing I would add there is there's still a lot that we don't know about how well these antigen tests work. But certainly when used in just general populations and asymptomatics, the recommendation is that these tests would be used in individuals who are showing symptoms of COVID. And we've, have some results that say how well the tests work in those populations. And so we've had to make some assumptions in the modeling about how well these tests would work more broadly. And we've tested some of those assumptions. So you'll see that in the report as well.
Next, we'll go to Hannah Kim with Q13.
Hi, thanks for taking my questions. So I just wanted to have some clarification questions for you guys. So did I hear that there have been only 110 cases of COVID linked to schools, as in students and teachers? Did I hear that right?
To clarify, those are cases that have been linked to the outbreaks that were reported to us. So there could be additional cases that are single cases. A reminder that an outbreak is 2 or more cases with plausible signs of transmission happening in that location, in this case, a school. So local public health does those investigations when an outbreak happens, and then they report the outbreak and the cases that are linked to us. There is sometimes a delay in this data, but that is what has been reported to date among those 42 outbreaks.
Because the report that Klein released indicates that that's really not the end all be all here. It sounds like you guys are saying that really when it comes to the most effective countermeasure, it should be symptom screening rather than rapid testing or diagnostic testing. Is that correct?
I can clarify a little bit there. And so what we see in this report is if we're in a setting where community transmission is relatively low, and at the same time, those countermeasures are implemented completely. So symptom screening, the non-pharmaceutical type interventions, distancing and hygiene and that sort of thing, then we don't think that there's going to be very much transmission happening within schools. Perhaps that's consistent with some of the data that Lacy and Kathy shared. And so adding on top of that, testing everybody routinely, every week or every other week, basically what we're saying is that many of those tests would come back negative. Where the value is potentially understanding some of the differences as you look around different parts of counties or different parts of the state, really assessing in the population that's present at that school, how many of those people might be infected, so you can learn a lot through that. And additionally, if some of those countermeasures aren't working quite as well, if we don't think that symptom screening is working well, then again, there's more value for doing this type of diagnostic screening on top.
Yes, and just a quick reminder for everyone, in Washington State, there are health and safety measures or non-pharmaceutical interventions that are required for any school, private or public, that is doing in-person learning, and that does include the daily symptom monitoring or screening for all students and staff, as well as things like wearing masks or face coverings, maintaining 6 feet of physical distance in as many locations as possible across the school environment, increased hand hygiene, cleaning, and improved ventilation, as well as being ready to respond quickly, both from a public health side and a school side, when you have cases, so that you can get people tested and do the contact tracing and get people isolated and in quarantine and stop those chains of transmission so you don't end up with an outbreak.
Next, we'll go to Bellamy Pelthorpe with KNKX.
Hi, yeah, so I just want to make sure I'm understanding the modeling correctly. It seems to be indicating that, you can bring kids back to school as long as you have countermeasures in place and, do so pretty safely. So I guess if that assumption is correct, then I'm wondering, is there a specific threshold that needs to be met, at which point the health department and school systems would bring students back in person, or, what is it going to take in order to get to that point? Because I think that's what a lot of parents are really wanting to know.
Yeah, so I can start just from the modeling perspective. The work we've tried to do here is just trying to quantify what those risks are. And, if we said none of these scenarios are zero risk, but there are ways to mitigate some of the worst outcomes. And so I've just been trying to be careful about quantifying what the risks are, but trying to assess what a safe level is a challenging thing.
So I'll quickly add, the decision to open up a school and provide in-person learning is a local decision in Washington State. The Department of Health has issued guidance that sets some benchmarks or thresholds for community transmission at which we think you can start phasing in-person learning. And right now, those thresholds are at or below 75 cases per 100,000 over a 14-day period. There is an exception to do small groups if you were above that threshold. And then, we recommend that you start with elementary students, and if that goes well, you can phase in additional middle and high school students. And certainly when you get to the low threshold, which is currently 25 cases per 100,000 over a 14-day period, we really hope that you're able to provide some in-person learning for all your students. This is a local decision because it's a very complex decision, and you have to have all of the infrastructure in place, the staff, the supplies, and the systems and policies in order to do all those countermeasures and respond. I will say that based on what we're seeing across the country, we are looking at those thresholds, and we don't have a recommended change at this point. We're always looking at those thresholds alongside the literature, what we see here in Washington State and in other schools, and considering how to improve or refine them, because there is a real cost to students and families when children can't be in the buildings. And also, we want to make sure we protect them and the staff when we do bring them back.
Do you have a follow-up, Bellamy?
Yeah, just a reminder, how many parts of the state are close to that 75 per 100,000 threshold, and what would it take to get there?
So this is Kathy. I can start. Well, unfortunately, with our outbreak growth, our outbreak has been increasing. Our COVID activity has been increasing, and unfortunately, with that, many of our counties are now have rates that are higher than 75 cases per 100,000 per 2-week period. This is a result of, I think, all the decisions that we make in our personal lives. I do think that we can drive our numbers down and, get our kids back into school. If we all can, commit to really limiting our social interactions, limiting the number of times you're with the number of other people during the week. And then it's also incredibly important that people are, wearing a mask whenever they're out with the people outside of their household. We now have good data that shows that people are really good about wearing masks when they go to the grocery store or the pharmacy, or need to run an errand. Where we are not so good is that when we have a friend over and, have a meal with a friend in our house, or have other, friends over to gather. There's some really good data that came out of Western Washington University that showed that only 50% of people report wearing a mask in those private settings. And we really think that that's where a lot of the transmission is happening right now. So, we all need to commit to this. We've bent the curve, and I'm really confident that we can do it again. It's harder this time around because people are tired of the pandemic. People have pandemic fatigue. I completely understand that. But it's so important to all of our communities to bring rates down so we can help kids get back in school.
Next, we're going to have Lacy Fehrenbach with Seattle Times.
Hi there. Good afternoon. I'm wondering about the status of the 2.3 million tests that we were supposed to receive between September and December from the federal government, and how many of those will be distributed to schools, and if we have them already in hand.
I can start. They're coming to us in periodic shipments, so we do not have all of them on hand. We expect them to arrive about weekly they started in late September, I think, through probably the end of December. We have been allocating them, as Dr. Lofi said, to places that serve as really important community access points for testing, places like critical access hospitals, community health centers, federally qualified health centers, local public health agencies. We also have some plans to use some of these tests for other congregate settings, such as correctional facilities, long-term care facilities, et cetera. However, we have, at least temporarily, carved out an allocation of about 1 million that could be used for schools as we learn more about these tests. Dan alluded to this, the specificity and sensitivity for these tests is most ideal performing when you have symptoms. And so, we're trying to think through, certainly with schools, any testing strategy we use, that we use, the right test for the right situation. So as we wait for tests to come in and certainly wait for more students to come in the building for in-person learning, we're working with our local public health agencies and education partners to think about those testing strategies in schools and not limiting it only to the use of those Binax tests.
You have a follow-up, Hannah?
Yeah, thank you. I'm wondering what impact this new report from IDEA might have on DOH's decision-making when it decides to send those tests to schools. As Daniel seemed to indicate, and please feel free to clarify, it seems like it would make the most sense to send these tests to places where schools have opened and community transmission is still high. But correct me if I'm wrong, I'm just wondering if this report will have any effect on that type of decision-making.
So we absolutely use the Institute for Disease Modeling reports, this one and others, to inform our decision-making. Certainly supplement that with additional inputs, including what we can find in the literature, what we know about the tests, what we know about disease burden in our state, and what we're learning from early movers in our states, and we would do the same on the testing in school side as well.
Next, we'll go to Lindsay Madrick with Point 6.
Hi, I just need something clarified, I guess. And looking at your presentation, it says, the hybrid and K through 5 phase-in are not much riskier than all remote learning. So why not move to that sooner? Why wait until next year if it really is not any riskier? Because I know a lot of parents who have jobs are having a tough time, especially with those little kids at home. What can you say to parents who see that and say, yeah, let's go back?
So again, want to emphasize, we do think that you should start with elementary grades first in terms of expanding in-person learning. We know that many counties and districts were on a path towards bringing some elementary students back into buildings in late October. A lot of those plans have been put on pause because of the increasing case counts that we're seeing right now. We do recognize this is a local decision and are working with our education partners and our communities, but like the reality is right now our disease trend is kind of going the wrong way to expand in-person learning much. We are definitely, as I mentioned earlier, looking at our statewide guidance and working with stakeholders on this issue. It does, I also want to acknowledge, it does take schools and it takes any sector time to get ready to do this. And so the schools also need to have good plans in place for how they will do all of the health and safety measures that are required by our guidance and that really lower that risk, as you saw in Dan's charts.
Yeah, and I didn't get a chance to show in this presentation. You're right that the main conclusion is, as you said, but there's a number of what-if scenarios where things could be slightly worse than we had initially estimated. So, for example, we've stressed the level of transmission that's out there in the community, and that certainly is one that pops up as important. Another one is if there's a higher level of asymptomatic infections, so that symptom screening wouldn't work quite as well. If more children have the infection than just aren't showing symptoms, or teachers and staff as well, for that matter. In addition to if the NPI aren't working as well, or symptom screening isn't taken seriously, those are some of the considerations that you would imagine, might vary some of those main findings within in our results, and you'll see those described later towards the end of the report.
Next, we'll go to Glenn Farley with King TV.
Hey, how are you doing? Give me a little bit more. This has been very school focused, and I understand why, but everything is operating in the broader context. You know, when I think about what happened in earlier in the year, March, April, we were heading sort of out into a warmer part of the year, more people outside. Now we're sort of heading into that in what's normally a cold and flu season. What is your expectation moving forward into January, December, those kinds of months, more broadly with the schools in that context?
This is Kathy. I can start, and then maybe Lacy, you can join in. First of all, I just want to say that I'm extremely concerned about our state's increasing trend in COVID-19 activity. We are clearly in our fall surge, and our activity is going the wrong way fast. Yesterday, we reported almost 1,500 new cases of COVID-19, which was the highest number the state had ever reported in a single day. So we are very concerned about what's happening. As we all look around the country, we see how this can really quickly get out of control. And I think many of the public health experts have agreed that we are really in, I think, what may be which will likely be some of the hardest months of our pandemic, because there's evidence that this disease transmits more during the winter months. Evidence that it's a seasonal virus, and the weather is turning and people are spending more time indoors. We've also learned that this infection can be spread by aerosols, and ventilation is incredibly important. Masking can happen. But the bottom line is, we're very concerned overall about the direction of this outbreak in our state. And, we talk about this every day. We all really need to take immediate actions in order to avoid having to put new restrictions in place and really to prevent our hospitals from becoming overwhelmed. This is happening around the country. The healthcare systems are becoming very busy, and we all want to be able to get care for any disease if we're sick and we need it. And if our hospitals are overrun with COVID patients, people are not going to have access to the excellent care that they normally receive here in our state. So lots of discussions about this, lots of concerns at the state level about our current direction.
And I'll just add what the future looks like a few weeks from now and in January depends entirely on what each of us choose to do today and in the next few weeks. So, we all have to double down our efforts to wear our masks, watch our distance, and really think carefully about our social gatherings. We know that humans need connection. We feel COVID fatigue too as responders in this event. We really encourage people to choose the activities and the social connections that will mean the most for them and sort of give them that human interaction and joy in their life, but to really limit them. So you're not doing a new activity somewhere out in the community every single day. You're picking a couple a week and certainly trying to keep them in really small groups of people. A reminder that in Washington State right now, you're only supposed to gather with 5 or 10 people outside your household at social events, 5 if you're in a phase 2 county, 10 if you're in a phase 3 county, and that's per week. So we have to think really carefully about how we do this, and then when we get together, do them as safely as possible. Be outdoors if you can. Even if it's raining, even if it's cold, bundle up and get an umbrella or sit under an awning. If you have to be inside, it helps to open the windows. And when you're together with anyone outside your household, please wear a mask. If we want to open schools or even get more kids back in school, whether it's a few weeks from now or in early January, if we want to celebrate the holidays with a few close friends and family, we have to double down our efforts right now. And really importantly, just as Kathy said, if we want to keep our healthcare system from being overwhelmed, we need to act now.
I just want to clarify briefly on the modeling as well. For this work, we've assumed we're in a relatively constant situation. We haven't modeled a situation in which COVID is expanding rapidly, very much like we're experiencing in this fall wave. So with increasing transmission out in the community, we've shown that you can get increasing transmission propagating through schools and elsewhere. So really doing everything that we can, just as you heard the experts say regarding mask wearing and doing your part is what we need to get those schools open.
And the final question today comes from Hannah Kim, who had a follow-up. Quick question for Dr. Klein.
Hi, Dr. Klein. Yeah, I think you answered a little bit of the question I was going to ask because, you're going to have parents who are confused later when they hear this because they're hearing that their school districts are listening to their local health departments and pulling back, even in early October when your study was being done. But then now we're hearing that really the risk is really not that much. Almost like the study is telling people, hey, you can open up schools. So is that still the case? Even with rising numbers, does your study still apply here? Do you stand behind the fact that schools can use it to open up right now?
Yeah, no, I understand your question, and it's super relevant, just considering the previous discussion we had surrounding increasing levels of transmission. And we haven't yet used the model to study situations in which you'd have a higher case incidence rate, above the 75 level, or in a situation where you're in an expansion. If that reproduction number is above 1 and each infection is causing 2 and 4 and 8, we haven't yet used the model in that type of situation. So I can't comment quantitatively on what the increase in risk might be in those types of settings, but we'll work to try to get those numbers out as we can.
All right. This concludes today's media briefing. I want to thank our panelists, in particular for Dr. Klein, making himself available and providing such a wonderful presentation on what we're seeing out there. I'd also like to extend a thank you to TVW for hosting the live stream of this briefing and archives of past COVID-19 update briefings. You can also find past briefings at the Department of Health's YouTube account. We'll close out and have a great day.